So again, if you go back to the phase 3 registrational clinical trial that just recently got published in the Journal of Clinical Oncology, the dose reduction guidelines were left to the treating physician and the investigators in some ways. The drug is generally very well tolerated. The dose-limiting toxicities, again, can be hematologic or non-hematologic. The hematologic toxicities are neutropenia and neutropenic fever, but an occasional patient can even see some severe thrombocytopenia. A lot depends upon how heavily they've been treated prior to initiation of Yondelis. So the dose reduction for hematologic toxicities is again left to the discretion of the treating physician. There are patients who will have a transient drop in their platelet count to 20,000 but recover quickly. Even if they needed a platelet transfusion, as long as there were no consequences of that, one could maintain the same dose to get the maximum benefit. On the other hand, if the clinical judgment suggested that this is a fragile patient and the risks were high, you could dose reduce by one level from 1.5 milligram to down to 1.2 milligram, for example. And similarly for febrile neutropenia. If the episode was uncomplicated, I think it's the clinician's decision as to whether dose reduction in that given patient is absolutely mandatory, or can the patient maintain the same dose to get the maximum benefit. The non-hematologic toxicities are a little different. I think the liver toxicities in particular, the transaminitis that patients could get, can create some life-threatening situations. So liver toxicity in terms of transaminitis, elevated bilirubins, or an obstructive pattern with elevated alkaline phosphatase is taken a lot more seriously, I think, because that clearly can have some life-threatening implications for that given patient.